Hello, everyone. Thank you so much for joining us today for this really important webinar hosted by the Canadian Spondyloarthritis Association. My name is Brenda Delodder, and I'm the Executive Director of the CSA. And we're excited to kick off this mini series on psoriatic arthritis to provide education, support, and answers to many questions we know patients and families have. And today's session we've titled Psoriatic Arthritis, What's Happening to My Body? And this is designed especially for those who are newly diagnosed or still trying to make sense of their symptoms. And we'll talk about what PSA is, how it affects more than just the joints, and what signs and symptoms people should look out for. I am honored to introduce our guest expert, Dr. Dafna Gladman. Dr. Gladman is a world-renowned rheumatologist and one of the foremost experts in psoriatic arthritis. Dr. Gladman is a researcher, clinician, and founder of the Gladman Krembil Psoriatic Arthritis program and current co-director of that program, and is also the co-director of the Lupus Clinic, both at Toronto Western Hospital. Her innovative research has transformed the care of autoimmune diseases like psoriatic arthritis, leading to breakthroughs in diagnosis and treatment worldwide. To add to this, she has recently been appointed to the Order of Canada, one of the country's highest civilian honors. Dr. Gladman is more than a trailblazer. Her research has shaped much of what we know today about the condition, and we're also grateful she's with us to share her expertise. Welcome, and thank you for joining us, Dr. Gladman. And just before we dig into this topic, I wanted to point out that spondyloarthritis is a complex and often debilitating condition that can be significantly impacted by the lives of those it affects. And it is the most prominent form of inflammatory arthritis, with more people living with the disease in comparison to rheumatoid arthritis. Today, more than 500,000 Canadians live with this incurable disease, including axial spondyloarthritis, psoriatic arthritis, enteropathic arthritis, among others. And as a disclaimer, the information provided by the Canadian Spondyloarthritis Association is not designed or intended to constitute medical advice or to be used for diagnosis purposes. Consult your healthcare provider for guidance tailored to your needs and medical history. So let's begin with the basics. Many people hear the word arthritis and immediately think of osteoarthritis or rheumatoid arthritis. But psoriatic arthritis, or what we'll refer to it as PSA, is really quite different. Dr. Gladman, can you explain what makes PSA unique and how it stands apart from other types of arthritis in terms of the core symptoms and disease process?
So, it is true that psoriatic arthritis had a difficult time getting recognized. In the early years, people used to call it rheumatoid arthritis and psoriasis. And it was only due to work by the late Professor Werner Wright from Leeds, England, that psoriatic arthritis became recognized as a single entity on its own. Dr. Wright presented most of the features of the disease, but we now recognize that psoriatic arthritis is an inflammatory form of arthritis. In this part, it does resemble rheumatoid arthritis in that they're both inflammatory forms of arthritis. Psoriatic arthritis affects about 30% of patients who suffer from the skin condition psoriasis. Psoriasis presents with red, scaly lesions, any part of the skin, and occasionally, in about 10% of the patients, the patient presents with the arthritis first. But in close to 90% of the cases, the arthritis actually follows the development of psoriasis or occurs at the same time as the psoriasis presents. The disease presents with pain, stiffness, and swelling in the joints, and that's the arthritis. It is worse with inactivity. It usually gets somewhat better with movement. And in terms of this peripheral arthritis, which affects the upper and lower extremities, It is different from rheumatoid arthritis in that it often presents with inflammation in the end joints. We call them the distal joints of the fingers or toes, whereas rheumatoid arthritis usually presents with arthritis in the what we call proximal. These are the joints, the knuckles that are closer to the wrist, and the middle knuckles of the fingers and toes. So there is an explanation here. And as I'll explain about the other features of the disease, I will highlight what again is different from other forms of arthritis. So about 50% of the patients with psoriatic arthritis develop arthritis of the back. It's called axial disease or spondylitis, which puts it in the spondyloarthritis group of conditions. That presents with back pain and stiffness, again, worse with inactivity, improves with activity. The arthritis may lead to deformities and joint damage, resulting in functional impairment and reduced quality of life. And the back disease does not occur in rheumatoid arthritis. Back disease does occur in osteoarthritis, but it's not inflammatory in osteoarthritis. So in osteoarthritis, a patient would complain of pain worse with activity, better with rest, whereas in inflammatory arthritis, inflammatory spondylitis as well, there will be pain and stiffness more with inactivity. Likewise, for the peripheral joints, the distal joints of the fingers and toes can be affected by osteoarthritis, but it's not inflammatory. And when one assesses the patient, one can see that when you have an inflammatory arthritis, you have swelling which is kind of juicy, as opposed to the swelling that one sees in osteoarthritis, which is bony. So these kinds of things actually help us differentiate the various forms of arthritis. Now, psoriatic arthritis may lead to deformities and damage, resulting in functional impairment and reduced quality of life. And while we don't know what causes the disease, we know that there are hereditary factors. We know that there's an effect of the environment. So carrying heavy objects and infections may predispose. And there is an effect on the immune system, which leads to the inflammation. So while we cannot cure the disease, we certainly can provide control of inflammation, which makes patients feel better, become more functional, and have better quality of life.
Mm-hmm. Yeah. Thank you for that differentiation. It definitely is complex. And so one of the most challenging things for patients is that PSA doesn't just stop at joint pain. It's a whole body disease. And can you speak to how PSA can also affect the skin, the nails, cause fatigue, and impact one's mental health?
That's a very good question. Psoriatic arthritis has several domains. So we already mentioned the peripheral arthritis that affects the joints of the upper and lower extremity, the axial disease or spondylitis that affects the axial joints, which are the joints of the spine and the sacroiliac joints in the pelvis. It also has dactylitis, which is inflammation of the whole digit, and that results from inflammation in the joints as well as in the soft tissues. We have enthesitis, which is inflammation in the tendon and ligament insertion into bone. So people know about plantar fasciitis or Achilles tendonitis, and these fall into the enthesitis area. And there are many other sites in the body where one can identify inflammation. The psoriasis, as we said, is a skin disease which presents with red scaly lesions in the body, and the nail disease, which presents with pits in the nails or a breakdown of the nail that we call onycholysis. So, a result of the inflammation, various parts of the bodies may be affected. And in addition, there are other manifestations that we call extra articular or extra musculoskeletal manifestations that include inflammation in the eye, which is iritis,
Mhm.
and inflammation in the bowel, which leads to inflammatory bowel disease. And we know that a condition called Crohn's disease, for example, is more common in patients with psoriasis than it is in the general population. And we know that iritis is more common in patients with psoriatic arthritis than it is in the general population, as it is in the other forms of spondyloarthritis. Now, in addition, that inflammation that occurs in so many parts of the body is a risk factor and is associated with subsequent development of other things. So, fatigue, lack of sleep, anxiety, and depression may occur just because somebody has pain. But the fatigue is also may be related to the inflammation itself, and the anxiety and depression may be associated with the inflammation itself. Because even in anxiety and depression that is not part of another condition, there is evidence of inflammation.
Mm. Wow.
In addition, patients with psoriasis and psoriatic arthritis are also predisposed to heart attacks and strokes. And so it is important that we control that inflammation both in the skin and the joints in order to prevent these untoward effects that might occur in this patient population.
Hmm. It's really interesting. The term that comes to mind is unpredictability for me, right? It
It's,
just seems like it's an unpredictable disease.
yeah, we call it variable course and prognosis.
Okay. And so, for some who may be living with unexplained joint pain or skin symptoms, it can really be confusing to know when to take that next step. What symptoms should people really be paying attention to, and when should they consider seeing a doctor or a specialist?
So, as mentioned earlier, the joint manifestations lead to pain, stiffness, and swelling. And the typical joints, as I said, are the end joints of the fingers. So, this may be accompanied also by limitation of movement. And the back disease presents with back pain, which is usually worse at night and improves with activity. So people should seek medical help if these symptoms occur, particularly if they already have psoriasis,
Mhm. Yeah.
because that we know is a risk factor for developing psoriatic arthritis.
Mm.
And so people should pay attention to any of these symptoms and request a referral to a rheumatologist. I mean, and our studies show that patients with psoriasis likely to develop psoriatic arthritis actually suffer from pain and fatigue prior to the diagnosis of psoriatic arthritis.
Hmm.
So it definitely is important to seek medical attention when these things happen.
Hmm. And so, for someone who has been diagnosed with psoriasis uh, by a dermatologist, what questions should they ask their dermatologist? What would the next step be to?
It's interesting. We are actually advising the dermatologist to ask the patient whether they have any joint pain, stiffness, swelling, and whether they have any back pain, stiffness, and limitation of movement, particularly improving with activity.
Hmm.
So um, the patient may ask the dermatologist if they are at risk for psoriatic arthritis and whether they should see a rheumatologist. And the dermatologist would then ask them the right questions
Hmm.
and decide whether or not a referral is appropriate.
Hmm. Excellent. And so, when people often we'll hear from patients who've struggled for years before receiving a diagnosis. Can you walk us through the diagnosis process? So, what tests are typically done, and what makes this diagnosis a little bit more tricky or difficult or delayed?
So again, a study that was done by Leahy Eder actually has demonstrated that even rheumatologists do not make the diagnosis right away. There are delays in diagnosis even when a patient has seen a rheumatologist of anywhere from 3 to 5 years. And that's partly because not all rheumatologists are as well versed on psoriatic arthritis. And obviously, we try to change that through our Spark program and other programs in terms of providing continuing medical education. Generally, what happens when a patient has these symptoms that we mentioned, like the pain, the stiffness, etc., they're usually assessed by the family doctor. And the family doctor would then refer them to a rheumatologist if they feel that there is a suspicion. Now, sometimes the family doctor doesn't know that the patient has psoriasis. I had a patient come to me, was assessed by a student in my office who missed the diagnosis because he didn't ask her about psoriasis and um, and I didn't ask her whether she has any skin lesions. I asked her, um, "How long have you had psoriasis?" Because when I examined her, I saw right away that she had a typical picture. She had a dactylitis. So it was typical for psoriatic arthritis. And then I said, "So where is your psoriasis?" And she said to me, "How do you know? I never told anybody." And the reason, I mean, she didn't tell anybody because she didn't make the connection. But a doctor who must have seen her should have looked to see whether she had psoriasis. She had lesions in areas that were not obvious.
Mm.
And so, like at the back of the head, in the umbilical area. So these areas are not obvious. And in fact, there was a study that was done in Britain, not in Britain, sorry, in the Netherlands, where in about 2003, they reported that they sent two patients separately to 15 rheumatologists. And many of the rheumatologists did not make the correct diagnosis because they didn't undress the patient, they didn't look for psoriasis, and they also didn't send them for the right investigations.
Mm-hmm.
But so it is a problem. Now, it's less of a problem in this decade than it was 2 decades ago because of the continuing medical education that's taken place all over the world, partly through, we have a group called GRAPPA, which is the Group for Research and Assessment of
Mm-hmm.
Psoriasis and Psoriatic Arthritis, that we actually started in 2003. And this group provides a lot of education to rheumatologists, to trainees, and to general medical community and all over the world. So hopefully things will continue to get better. But in any event, the rheumatologist assesses the individual by obtaining first a history of the condition, examining them for any evidence of inflammation, including the skin, and
Mm-hmm.
then performing laboratory tests to identify the form of arthritis that they have, because like rheumatoid arthritis would be associated with a test called rheumatoid factor or anti-CCP. And psoriatic arthritis, occasionally patients do have that, but very small percentage.
Mm-hmm.
And obviously, we do get this positive rheumatoid factor as we get older. So we have to always judge appropriately. And then x-rays to see if there's been any joint damage and which joints are involved and whether there's any back involvement. Interestingly, patients with psoriatic arthritis who have back involvement don't complain of as much pain. And we don't know whether it's because they're so overwhelmed by the pain in the peripheral joints or there is another mechanism
Mm.
that is not associated with a lot of pain.
Mm.
So sometimes an ultrasound or an MRI may be necessary if the doctor is not convinced that there is inflammation. They sometimes want to do that to make sure that they haven't missed anything. And there are classification criteria called CASPAR, classification criteria for psoriatic arthritis, and patients may use that as a guide to make the diagnosis. But
Mm.
generally speaking, it's a clinical diagnosis.
Mm-hmm.
If you have psoriasis and you have arthritis, it's likely to be psoriatic arthritis, although you have to rule out the possibility of psoriasis being associated with other forms of arthritis like rheumatoid arthritis, osteoarthritis, gout, because
Mhm.
uric acid may be elevated in people with psoriasis because they have a lot of skin turnover. So sometimes it's difficult,
Mhm.
but still needs to be done.
Yeah, absolutely. And we talk a lot about self advocacy here at the CSA. And something that you pointed out regarding skin lesions that aren't visible, and perhaps a message to those living with arthritis is when they go to see their next medical, when they're attending their next medical appointment, to mention that they have skin lesions. That,
Absolutely.
yeah,
Absolutely. That's a very important fact.
yeah, great. And so the earlier PSA is caught, the better the outcomes.
Absolutely.
But but why is that? Can you help us understand the risks of waiting too long or ignoring or this will just go away without timely care? What kind of
Okay.
tips?
So we know that inflammation leads to joint damage. So it stands to reason that if you treat the inflammation early, you would prevent joint damage. So that's one thing. However, there are two studies that actually showed that the longer one waits to be treated, the worst things are. So the first was our own study, where we demonstrated that patients seen within 2 years fared better in terms of progression of joint damage than patients who were seen after 2 years. Then there was a study that came out of Dublin, Ireland, where they assessed patients within 10 months of diagnosis, of presenting of symptoms on the average. And what they found was that patients that were within 6 months of onset of symptoms actually did much better in terms of um, in terms of patient function, quality of life, as well as joint damage. And when they looked at 2 years, people did even worse. Everything that was not significant in the first 6 months became very significant in the 2 year mark.
Mhm.
So there is evidence that early treatment provides better results for patients with psoriatic arthritis. Now, I can tell you from looking after patients in our own clinic, there is no doubt that the earlier we see the patient, the earlier we treat the patient, the better their outcome. And we are now seeing patients earlier in the course of their disease, and they actually are doing better,
Ah, it's excellent.
partly because we have better medications, but
Yeah, yeah, yeah,
but
that's
still, there's less damage already when they present to the clinic,
mhm.
um, when they come in. And we know from from our own studies that the presence of damage leads to more damage. So it's better to prevent the first damage from occurring.
Yeah, that's great. It's a great point there. And just as we wrap up here, people living with psoriatic arthritis, this disease doesn't just affect someone physically. It changes how people show up to work, in their relationships, their daily routines. Can you speak to the broader impact of this disease and how it impacts the quality of life?
Yeah, so I already mentioned that the inflammation in the joints leads to functional impairment, and it also causes a reduced quality of life. And we've shown that patients with psoriatic arthritis have a reduced quality of life compared to the general population. And while we know that even for patients with severe psoriasis, there is reduced quality of life, the additional burden of psoriatic arthritis actually leads to an even worse quality of life in psoriatic arthritis compared to psoriasis without arthritis. We've also shown that anxiety and depression are more common in patients with psoriatic arthritis than they are in patients with psoriasis alone. And interestingly, these are also associated with the degree of inflammation.
Mm,
So it's therefore very important to control inflammation so that we prevent some of these other untoward effects. And it's also important to get a good night's sleep, to exercise as much as possible. Exercise provides some pain relief because of the chemicals that are produced when we do exercise, and therefore it produces better quality of life. So even in patients without pain, they feel better if they exercise. So there is something in the exercise process that actually makes our life better. So I think that there are a few things that people could do for themselves. First recognize that they have something, see the doctor as early as possible, tell the doctor everything that they have so that nothing gets missed, and then do the things that they can do on their own while they're getting medical treatment from their physicians.
Yeah, that's really great advice. And that's a great way for us to wrap up here today. And I just want to thank you so much for your time and for really helping us to understand this really complex disease and what's going on inside the body when someone has psoriatic arthritis. And if you're watching this and are newly diagnosed or struggling with symptoms, please know that you are not alone. We invite you to explore the CSA website for more resources, including our patient discussion guide and the guidebook, which Dr. Gladman was an author of. And there's also a support network there. So thank you for being with us here today, Dr. Gladman, and thank you everyone for watching.
Thank you very much for having me.